All right, so let's get into, we're going to talk about Section I, which is active diagnosis, Section N, which is medication, and Section L, which is oral dental status. So we are going to start off with looking at Section I. So we're going to state the intent. We're going to look at the look-back periods. We're going to look at the intent for Section N. And we're going to talk about the purpose of each item. And then we're going to spend some time looking at the oral and the dental status. So let's start with Section I, which is our active diagnoses. And what we're looking for here is this section is intended to code diseases that have a relationship to the resident's current functional status, their cognitive status, mood and behavior, medical treatments, nursing monitoring, and certainly areas that may have risk to death. So when we identify diagnosis, it requires a documented diagnosis, and we can use the 60-day look-back period. So when we're looking at Section I, there's really two steps to Section I, and this is a good way to teach it. So we first say, do we have a diagnosis that is current within the last 60 days? So that's the first step. Once we determine we have a diagnosis that meets that criteria in the last 60 days, then we have to say, all right, well, now we have this diagnosis, but now we have to say, is it really an active or an inactive diagnosis? Have you ever been into a facility where you have a long-term care resident that has, the pre-printed order sheets come from the pharmacy? And how long are the diagnosis list? Right? 3/4 of a page. Back to the point that this, 98-year-old woman had, 3 cesarean sections or something. I mean, interesting to know, but is it relevant? Probably not. So we're going to say, do they have a diagnosis in the last 60 days? And if so, of those diagnoses, which ones are active in the last 7-day look-back period? So how are we going to do that? Well, the documented diagnosis needs to happen by that authorized practitioner, and you're going to see that same language. So this is that, the physician, the nurse practitioner, the PA, the clinical nurse specialist, as indicated by your state law, your state practice law. And what are we going to do? First off, we're going to review the medical record sources, and we list a variety of sources. Here, it's not an end-all and be-all list. You can look at the progress notes, the most recent history and physical. You may be looking at transfer documents coming from another facility or coming in from a hospital. We could look at discharge summaries. We could look at some facilities have a really nice diagnosis, active and inactive lists or problem lists. Or there may be other resources as available to your facility. So you want to take a look at these. And we're going to only include diagnoses identified in the last 60 days. Now, for those of you who may have looked at the very early versions of this manual, it was 30 days. People remember looking at that? And we started looking at this back in March when we started training with the RAI coordinators and the regional office staff. And it was something that even had been brought up by our team that said, well, why are you limiting it to 30 days when the regulation allows, if someone is stable, that a physician can come, right, every 60 days after you've had your initial visits, right? So we went back to the group, we talked with CMS, and they made the change and said, that is right. So if we're saying by regulation that a physician or practitioner can come in every 60 days if they're stable, why shouldn't we allow the active diagnosis to be within the last 60 days? I mean, the actual diagnosis within the last 60 days. So now we have this diagnosis. Now we're going to try to determine if the diagnosis is active. And how are we going to do that? Well, we can review the medical record again, and what we're looking for is in the transfer documents, a physician progress note, again, the history and physical, maybe doctor's orders. There could be nursing care plans, nursing assessments. We could be looking at diagnostic reports and other sources that will help to support that this issue is a current issue for the resident. Now, I have a little note that I wrote down for myself to announce to the group today. We have had some conversation and a decision was made. When the RAND Corporation was, Dr. Saliba and her group were doing the testing on this particular item, they had developed some algorithms to help staff to figure out whether the diagnosis was active or not. And she thought those were really great resources. So we have determined we're going to be looking at those algorithms. We're going to take those algorithms and format them for our manual and whatnot, and we will be adding them to an appendix. So that's coming, all right? And so hopefully that will help your staff when they're going to decide if they're struggling, is this active or not. They can go to the algorithm, kind of work it through, and make their determination on whether it's active or not. Some of them are going to be obvious. Others they may struggle a little bit more with. A timeline. Oh, well, timeline. I can't promise anything. We're the government, can't promise anything. We're going to work, we have a lot of things that we're taking away from this conference, and our team will work very diligently on it. We have to take it first, review all of them, make sure we don't need to make any adjustments, because the RAND did this study a couple of years ago, so we have to make sure it's current. Make any updates and changes. It all needs to be formatted and done to make all the compliance issues. But we will, I'll make the commitment, we will do this as quickly as possible. I could be a politician, couldn't I? Okay. No, seriously, you know, this is something that we're really committed to, and I sit on that team along with a lot of wonderful people, and we know how important this is to you, and I think it is a great resource, so we will work very diligently to get this out to you as quickly as possible and get it posted. So let's look at indicators of an active diagnosis. There may be specific documentation of active diagnosis in the medical record by a physician or a nurse practitioner or any of those other staff members that are allowed to do this. In the absence of specific documentation that a disease is active, meaning like, you know, for example, someone has a pneumonia and it's in that 7-day period, they've just ordered a chest x-ray, you have positive results, you've got the doctor's ordered an antibiotic for the pneumonia. Not too hard, right? I mean, doesn't take it's not a rocket science stuff. Maybe a little harder for other diagnoses to determine whether they're active in the last 7 days. In the absence of specific documentation that a disease is active, the following indicators may be used to help decide. Is it of recent onset or acute exacerbation indicated by a positive test or procedure? So, you know, did all of a sudden they have some symptoms, you went ahead, you've done a clinical workup, and now we have some the clinical indicators of we had a chest x-ray and it showed positive, we had an EKG that showed changes, we had blood work that showed something, so that it indicates that they've had an acute change, or we've had some symptoms and then we've initiated some therapy in the last 7 days. Some examples of recent onset of acute exacerbation could include a new diagnosis of pneumonia, which I talked about. They could have been hospitalized for fractured hip. That's pretty clear, right? Doesn't take, again, a lot. They may have had a blood transfusion for a low hematocrit. The source may include a radiological report, a hospital discharge summary, and whatnot. Symptoms and abnormal signs indicating ongoing or decompensated disease in the last 7 days. For example, all of a sudden you have someone who's having intermittent claudication in the lower extremity. They're having pain in conjunction with a diagnosis of some peripheral vascular disease would indicate an active disease. All of a sudden you're seeing a change in the person and they're having increased pain or maybe some issues. Or sometimes signs and symptoms may be nonspecific and could be caused by several diseases, and therefore we must kind of work through and see what they're related to. And then therefore, symptoms must be specifically attributed to the disease. So if you have someone presenting with multiple symptoms, we must decide what we're going to attribute to each disease. So for example, a productive cough would confirm a diagnosis of pneumonia if specifically noted as such by a physician or other practitioner, or you had that x-ray that said they had, you know, clinical findings of a pneumonia. Ongoing therapy with medication or other interventions to manage conditions that require monitoring for therapeutic efficacy or to monitor for potential adverse side effects could then indicate that we have an active disease. A medication indicates active disease that is prescribed to manage an ongoing condition that requires monitoring or is prescribed to decrease inactive symptoms so that you'd be having symptom monitoring. And this includes medications used to limit a disease progression and or complication. If the medication is prescribed for a condition that requires regular staff monitoring of the drug's effect or condition, then the prescription of the medication would indicate an active disease. So what does that mean? So if you have someone who is on warfarin therapy for atrial fibrillation, we're going to be monitoring that. What are we monitoring for signs of bleeding? We're going to be monitoring lab results, all of those issues for that person. So that could indicate we have active disease. So look-back period, I wanted to talk for a few minutes about UTIs. This is an area where, for the 3.0 manual, we've struggled a little bit with, and I'm really happy with what we've come up with now because it meets the current standard. It matches what we practice in the long-term care setting. So the look-back period for UTIs, 60 days to identify the diagnosis as it is. But here, instead of a 7-day to determine if it's active, it's a 30-day. So please, when you do training, here's something to point out. UTI is different from the others. It's a 30-day to determine if it's active. The next piece is all of the following criteria must be met to indicate that they had a UTI. They have to have a diagnosis of a UTI in the last 30 days. They have to have had signs and symptoms attributed to a UTI. They must have a positive test or study or procedure confirming a UTI. And then they must have a current medication or treatment for UTI in that 30-day look-back period. Does that make sense? Does that match what we do in practice? Right. So what we don't want to do is capture that facility for every fall they dip a urine and or they just call the doctor and all of a sudden we're sending off urines and we're going ahead and we're treating them without confirming that this is actually a UTI. So we may have to make sure that we have all of these components in place to determine if it is a UTI. So for Section I coding, we're going to check off each of the active diseases and the diagnosis listed by major categories. So if you look at your form, there's a lot more diagnoses listed. Examples are provided for each category, and diseases to be coded are not limited to the examples. So if you, when you go through and you read the manual, there's some examples, but please know, some people want to say, well, what if they have anemia due to XYZ, or what if they have this, or what if they have that? You didn't list it on the form. Well, on the form, we just gave you, right, it says EG. These are just examples. It's not meant to be an end-all and be-all list. So, again, just you must look at this, make the interpretation, and decide. And what we want to do for Section I is we're going to check all that apply. So depending as we go through, as long as we have that 60-day, we've determined they're active in the last 7 days, we want to then go ahead and code that item. All right, Section N, we're looking at medications. So here we're looking at a couple of items. In this section, the intent is to record the number of days during the last 7 days, or since admission or reentry if less than 7 days, that any type of injection, insulin, and or selected oral medications were received by the resident. So that's the intent for this particular section. Section N does not document the number of injections or medications received by the resident. And Section N focuses on the number of days during the look-back period that the resident received injections, as well as the types of medications that it's looking for here. So there's 3 questions, 300, 350, and 400. So the first one is N300, which we're looking at the injections. So we're going to document the number of days the resident received injections of any type. So this is not limited to just insulin. We're saying what kinds of injections did the resident receive? How many days did the resident receive an injection? So the look-back period is 7 days, or since admission or reentry. So we don't look back into the hospital, right? So this is so if they're admitted and you're doing a 5-day assessment and you literally only have 5 days, that's all that you have to look for. You can't go back into the hospital. And it includes any type of medication, antigen, or vaccine, including insulin injections. So even though we're going to be talking about insulin in the next question, if they're receiving insulin injections, you still count the injections here. All right? And you can, if you give a flu shot, you can count that. PPD, any of these things you can count as injections. And again, we're not looking at the number. Please remember, it's not the number of injections, it's the number of days. So if you only have a 5-day period to look back between the ARD and when they entered, could you have 7 days? No. Okay. So make sure when you're teaching that staff understand that. And it may be administered by subcutaneous, intramuscular, or intradermal injections. And again, I've already told you that. Do not record the number of injections. It's the days. So N300, we're going to count the number of days that the resident received any type of injection during the look-back period while the resident was in our nursing home. And we are going to take those days and we are going to just write the number of days that they had an injection. Pretty easy. I don't think it's that hard. But let's talk about N350A, which is specifically talking about insulin. So N350A is saying the number of insulin injections. So the number of days insulin injections were received by the resident. And then N350B is saying the orders for the insulin, the number of days insulin orders were changed for the resident. So review the resident's medication administration record, determine if the resident received insulin injections or if the insulin orders were changed, count the number of days the insulin injections were received, and count the number of days that insulin orders were changed. The look-back period is 7 days since admission or reentry. Let me go back here a bit. So let's talk about, I guess we took some slides out. Let's talk a little bit about insulin pumps. I don't know how many people are seeing the insulin pumps in the long-term care setting, but if someone has an insulin pump, it's the number of days when we're talking about the actual injections. You're going to count the number of days that you actually stick the resident. So you're changing the needle out and putting in for the pump. So if day 1 I'm starting off the insulin pump and I put a new needle in, day 2 they're still getting the insulin, but I haven't had to put a new needle in. We're not counting that day. Let's say day 3 I need to change that needle out and I have to change and restick them. Then we count that second day. Does that make it clear? Does everyone understand what I'm saying there? Okay, because that was a point of confusion in some of the other training. Let's talk just very quickly about insulin orders. This really hasn't changed so much from 2.0. So if you have a sliding scale for insulin, and you're giving varying doses based off of the predetermined scale, we wouldn't count that as new orders, right? You don't count it now as new orders either. But if it's the initiation of a scale, right, we'd count it. If it's a discontinuation of an order for insulin, we'd count it. If the doctor or practitioner adjusts, like rewrites a new scale based off of the history of the blood sugars, then it's a new order. So that hasn't really changed a lot, but I want to just make sure that everyone understood that. And any other injections related to diabetes that are not specifically insulin are not captured here. They could be captured under injections, but they're not. We're really just talking about insulin in this particular item. So here we have N400, and these are talking about medications received. And we're going to document the type of medications listed that were received by the resident during our 7-day look-back period or since they entered into our facility. And so what are the class of drugs? What are we looking at here? We are looking at the antipsychotics, the anti-anxieties, the antidepressants, the hypnotics, a new one, anticoagulants. And here we're specifically looking at warfarin, heparin, and the low molecular weight heparin, which is like your, I know I shouldn't say brand names, but the Lovenox, okay, that type of thing. Antibiotics, diuretics, or Z, they had none of the above. Now, when we're looking at this particular item, the look-back period is 7 days. It includes all medications administered while a resident of the nursing home, and code medications according to the drug's pharmacological classification. That's not new. We were doing that already. And include any of these medications given to the resident by any route in any setting. So what they're saying is, if someone had to go out to the emergency room, they're still your resident, right? They hadn't been admitted, maybe they had a visit, or they went out to the doctor and they were seen as an out in a physician's office and then came back to your facility. They're still your resident. If they, let's say they were given an anti-anxiety medication in that setting, we certainly want to capture it. So it's not like we had to just administer it. So it's in any setting as long as they were a resident of ours. And we want to make sure that we code the medication even if it was given only once during the look-back period. And we want to count long-acting medications that are given every few weeks or monthly, only if given during the look-back period. And that's a little different, okay? So for any of our long-acting medications, we're only going to count it if we gave the medication during that 7-day look-back period. It used to be that we could look at the effect of that medicine over the longer period of time. And let's look at combination medications. They should be coded in all categories that constitute the condition. So if it's something that is, so let's say it's going to cover an antidepressant and an anti-anxiety, we can count it in both areas. So you want to make sure that we capture that. Over-the-counter sleeping medications are not coded as hypnotics as they are not classified under a hypnotic drug. So if you're giving someone a melatonin, let's say, for example, to help them sleep, it wouldn't be counted here because it doesn't meet that classification. We've given you some references in the manual that you can click on that will take you to a website where you can look up if you're confused on what category a medication falls into or whether it is even counted as an actual medication or an over-the-counter drug. All right. So hopefully that clarifies. I don't think that's going to be too difficult for people. It's not a whole big change from 2.0. And now we're going to go on to looking at oral and dental status, which is section L. And what's the intent here is to record any dental problems present in the look-back period. Now, people asked a lot of questions in our April conference about, well, why didn't we include this and why didn't we include that and all of these different things. So the pivotal word here when you're teaching this is problems. So we're looking at things that are of an issue to a resident. And then we're looking at the look-back period. So what we want to do here is we're going to start by what? Talking to the resident. We're going to say to the resident, we're going to ask about chewing problems or mouth or facial pain or discomfort. So if we can talk and have a conversation with the resident, how are you doing with your food? Do you have any pain? How are your dentures fitting? How do they feel? Just get a sense from the resident how they feel their mouth is. Then ask the resident or responsible party, does the resident have or recently had dentures or partial plates? If the resident can't tell you, then we have to talk to a significant other. If yes, but the resident does not have them at the facility, ask for the reason. So if they said, well, yeah, they had bottom dentures, but they were lost in the hospital, or they had upper dentures, but with their cognitive impairment, it got to the point that they were constantly spitting their teeth out, and they became more of a problem for the resident. So they basically refused to wear them, but they're functioning fine. We certainly want to be aware of that. So you want to start to do your investigation and figure out what's going on. If they, had these, why are they not using them? Then it wants us to go ahead and conduct an assessment. Now, we're not dentists, right? We're not dental hygienists, although there may be some here in the audience. But as a rule, as clinicians, we are not a dentist. But that doesn't mean we can't look in a mouth and figure out where there might be a problem that we should make a referral. So we're going to examine dentures and partial plates for loose fitting. And this is really important. So take the opportunity to One, you can observe during a meal or see how the resident is functioning. Remember we talked earlier, you heard me talking about that person whose dentures are flopping. You know, the mouth's going one way and the dentures are going another. That can be a real issue. But even someone whose dentures just move a little bit, if you've ever talked to someone who has dentures, food gets up and behind and under the dentures and really can cause a lot of pain and discomfort for the residents. So we want to make sure that if someone has weight fluctuations, the general rule is a 10-pound weight loss for most people who wear dentures. Starting at 10 pounds or greater, if they have dentures, you can almost guarantee that their dentures are not going to fit as well. So you may want to talk to whoever your dental consultant is to work with you. If someone has this weight loss, what else should you be thinking about? If they have dentures, let's make sure those dentures are still fitting well. And then what are they using? What kind of, if they're using a denture adhesive or whatnot. We're going to conduct an exam of the resident's lips, oral cavity with the dentures and partial plates removed. Why? Let's take those dentures and those partial plates out, and let's get a flashlight in a gloved hand, if the resident will let you do it, and take a good look in the mouth and see, do they have sores, reddened areas? Do they have darkening or tattooed areas in their mouth? Is there anything that looks abnormal to you that you may want to make a referral to someone to take a further evaluation of it? And so we're looking at abnormal tissue, abnormal teeth. Do they have cracked teeth? It's amazing if a tooth cracks. I don't know if you've ever had that. I have a couple of crowns and a tooth crack. How sharp it is. You can cut the inside of your mouth. You can cut your tongue. It can be quite painful. And then certainly inflamed or bleeding gums. So they're saying use the gloved finger to adequately feel masses and loose teeth. All right. I agree going in and feeling if the resident's not going to bite your finger. I mean, sir, you have to use, your judgment here. If you can get in and the resident will let you go in and feel the gum line and stuff, please do it. Certainly, like I said, take a look. But if they're at all agitated and they're clenching down or there's a potential that they could bite, be careful. And then determine if chewing problems or mouth pain is present. And you can do this by observing the resident, talking to significant others, talking to staff members who are helping them or watching them eat. And you certainly want to report that. We're going to do a very quick video, and then we have a few more slides, and then we're going to wrap it up.
I'm excited to welcome you to the first nationally broadcast training program dedicated entirely to the oral health of nursing facility residents. Never before has this issue been given such wide exposure or this level of visibility. The mouth is easy to assess if you think in terms of the four major components of oral health that you are reviewing: the teeth, the gums, the soft tissue, and the appliances that a resident may have, such as dentures or partials. To look at in the resident's mouth, have a facility staff member, preferably a nurse or a CNA, help the resident open their mouth and retract the resident's lips. I can hear you now. What did he say? Get the staff to do what? Yes, I did say get the staff to help you. As a dental consultant during surveys, I've never been refused help by nursing staffs to do this. Staff members have always done a good job and have been willing to help. Remember, someone in every facility should be familiar with looking in the mouths, because looking in the mouth is required to properly assess the resident for the MDS and the care plan. Don't hesitate to ask for staff's assistance. I'd like to show you a video of how simple this process can be. I want you to notice on the video the man retracting the lips of this resident. He's the facility administrator, and I purposefully chose the first cut of this video to further prove how well this can work by facility staff. As you'll see, he did a very good job. Notice how he's retracting the lips, and we can see all the structures in the oral cavity that we need to review. Once the lips are retracted, you can look inside the resident's mouth and note your findings. A flashlight, which works best, or a pen light can greatly improve your ability to accurately assess the resident's oral condition. Most facilities have a light you can use. When viewing the oral cavity, make sure to review each of the four oral dental health components of the resident's mouth: teeth, gums, soft tissue, and dentures or partials. First, look at their upper and lower teeth or dentures or partials if they're missing teeth. After you've observed the teeth, dentures or partials in the mouth, have the resident, the nurse, or the CNA remove the dentures or partials and look at them to see if they're broken or dirty. Once they are removed, have the facility staff retract the lips again and continue. Now look at their teeth, gums, tongue, cheeks, and palate. This oral observation shouldn't take more than a few minutes and provides crucial information to you as you investigate if the resident's needs are being met. Make sure to record the time, date, and the names of all the people present when you perform your resident observation.
All right, so that was a quick video on how to complete an oral assessment. But let's take this a step further. So you've gone ahead and you've done the oral assessment, and you take out the dentures, let's say the top denture, and you realize there's a fair amount of food kind of trapped on the top and around. I think that, we really do a huge disservice to our residents when we're really not very aggressive. Some facilities do a better job than others in, especially residents who have plates and stuff, of making sure that we're doing oral care after every meal, making sure that those dentures and those plates come out, and we rinse them, and we encourage the resident to rinse their mouth out. Because now, let's say it's lunchtime. So our resident had their lunch, right? And now we don't rinse, they have dentures or partial plate or whatever, or maybe they don't even have that. Now we're ready to put them in for a rest, after lunch. What do you think could happen if we have a little bit of food on the side of the mouth or under the dentures, and we put that resident into bed for a rest? Right, aspiration. So it's really, when we think about it, I don't think that staff think long and hard enough about oral care related to how do we prevent aspiration. And this is one way that we can do it. And so if you've done an oral assessment, you pull those teeth out and you see that there's food and stuff underneath it, first and foremost, you're thinking they don't fit quite right. You probably want to have that evaluated. You could have those dentures relined or a variety of things done, or use sort of a paste. But you want to make sure we take them out, we rinse them well, get the oral care done, and now when we put them into bed, we've decreased the chance of aspiration tremendously. There is quite a bit of research being done. I'm from Connecticut, and Yale University is involved with a big study, and it's all about oral health in the long-term care setting. And so it'll be interesting. They're just in the beginning parts of this study. But looking at this whole idea of rinsing the mouth, rinsing the dentures, and then looking at comparisons with aspiration pneumonias and a variety of other things. So it's not only that people are aspirating while we're feeding them, but we could really be setting them up for an aspiration if we put them to bed without doing really good oral care. Now, oral care traditionally happens quite well as first thing in the morning and maybe last thing in the evening, but we're missing the opportunity certainly during the noontime meal, and then if we're putting them down for a rest, or they're going down for a rest themselves. So that is section L, and far as oral health. It's not a big section. It's a really quick section. It's not going to take you a lot of time, but the bigger thing is take the opportunity not only from coding the MDS, but take it to that critical thinking, take it to the next step, and not working in silos, kind of like what we talked about just prior to this.